There is only numbness in the fingers, but sensation is intact. We'll ask the doctor not to excuse. Okay. Uh, factors. Okay. Okay, it's malingering. Uh, this patient reports a left hand injury. This patient reports a left hand injury sustained while lifting a box. However, her sensory symptoms of numbness in a globe distribution do not follow an anatomic distribution or innervation. This marked disparity between the patient's reported symptoms and known nerve pathways should raise suspicion for psychosomatic disorder. Psychosomatic disorder, which are differentiated by whether the symptoms are intentional and whether secondary gain is being sought. Malingering is feigned or grossly exaggerated physical or psychological symptoms reported with the intention of obtaining secondary gain, leave from work, narcotics. Factitious disorder is false physical or psychological signs or symptoms intentionally produced to assume the sick role rather than achieve a tangible secondary gain. Conversion disorder. Conversion disorder is unexplained neurologic signs or symptoms that are incomplete with recognized neurologic condition, differentiated from malingering and the factitious disorder by the lack of external incentive, secondary gain, and intentionally produced symptoms. These patients appear to be malingering in addition to the clinical inconsistencies. She is reluctant to allow the necessary physical examination and requests a work note. These behaviors suggest she is feigned symptoms for secondary gain. Mm, Secondary gain. Patients with malingering should not directly confronted about their behavior. Rather, they should be told that the physical cause of their condition have been excluded and their requests secondary gain, that is providing a note for work, cannot be granted. Okay. Okay, other symptoms like symptoms of complex regional pain syndrome. Symptoms are like complex regional pain symptom typically begins 4 to 6 weeks after traumatic extremity injury and include severe gain, swelling, and sensory abnormalities, motor deficits, changes in the skin color and temperature. Okay, in lunate dislocation and volar displacement of the lunate can compress the median nerve, and the median nerve symptoms will be found. Okay, scaphoid fracture occurs after a fall on outside hand. Lifting a box is extremely unlikely in the unlikely mechanism of the injury. Okay, a box. Psychosomatic disorder intentional falsification or exaggeration of illness, and gain, secondary gain. And difference between conversion and malingering is there is no specific goal or no secondary gain in conversion disorder. Just unintentional neurologic sign symptoms incompatible with anatomy or pathophysiology. And factitious disorder is intentional fabrication of the symptoms or self-imposed injury or illness. Goal is assumed sick role, no tangible secondary gain. Got it? Okay, it's cyclothymic. There are okay. This patient's history of chronic fluctuating mood disorders. Chronic fluctuating mood disorder. Can you hear me? Okay. So this patient's history of chronic fluctuating mood disturbance for many years is suggestive of cyclothymic disorder. Cyclothymic disorder. Her symptoms are mild and she does not have sufficient history to diagnose. She does not have sufficient history to diagnose either a current or past major depressive or hypomanic episodes. Cyclothymic episodes falls within the bipolar spectrum and represents a less severe form of the illness. Diagnosis requires 2 or more than 2 years of duration, 1 year in children, and insufficient number of symptoms and severity to meet full criteria for hypomanic, manic, and depressive episodes. Criteria for major depressive episode include 5 or more than 5 of the following symptoms over 2 weeks. Psychic apps like sleep disturbance, interest lost, guilt, energy low, concentration impairment, appetite loss, psychomotor retardation, and suicidal thoughts. Patients should be evaluated for a bipolar 2 diagnosis. Patients should be evaluated for bipolar 2 diagnosis if they meet these criteria. If they meet these criteria and have a history of hypomanic episodes 4 or more than 4 days of elevated irritable mood, increased energy, and 3 or more than 3 of the following: grandiosity, decreased need for sleep, talkativeness, racing thoughts, distractibility, hyperactivity, and risky behavior. Okay. Next. Yes. Everything is regarding gambling because gambling is very, uh, what can I say? Okay, gambling disorder. Gambling disorder is defined as persistent and maladaptive gambling behavior. Persistent and maladaptive gambling behavior that results in impairment or distress. It is considered a non-substance behavioral addiction. Non-substance behavioral addiction. A non-substance behavioral addiction implying implying many shared feature, anticipatory craving, chronic relapsing course with substance use disorder, mood symptoms related to gambling behavior, irritability, feeling a down, and are common as seen in this patient. The diagnosis requires 4 or more than 4 of the characteristics related to problematic gambling behavior. This patient exhibits the following: preoccupation with gambling, frequent return to gambling to attempt to recover past losses, tendency to damage relationship and jeopardize employment, and reliance on others to make up financial losses. Additional criteria listed in DSM-5 include gambling when distressed, depressed, or anxious, increase gambling to achieve the desired excitement, irritability, distress when trying to cut back or gambling, and repeated unsuccessful attempts to cut back on or and conceal the extent of the behavior. Treatment approaches include cognitive behavioral therapy and participation in self-help programs. Gambler Anonymous. Okay, why it is not bipolar disorder? Patients with bipolar disorder may gamble and spend large sum a large sum of money during a manic episode. Mania, however, is episodic and unlikely to be persistent over a year. Diagnosis require the presence of other manic episodes, including increased energy, general decreased need for help, not associated only with gambling, increased goal-directed activity, flight of idea, and pressure speech. Next. He has no tendency to harm the baby, isn't it? Um, okay, it's postpartum blue. This patient's mood disturbance is most consistent with postpartum blue, a normal self-limited condition that occurs within a few days of postpartum. Symptoms occur in 40 to 80% of women, including mild depressive symptoms such as tearfulness, irritability, dysphoria, anxiety, insomnia, impaired concentration. These symptoms are typically peak at 5 days and resolve within 2 weeks. The most appropriate response is to reassure the patient that her symptoms should improve shortly and instruct her to call if they do not remit spontaneously, helping the mother obtain adequate rest and assisting with childcare if needed are also beneficial. Although the majority of the women with postpartum blue will recover spontaneously, these patients are increased risk of developing postpartum depression. They should be monitored for symptoms that may include postpartum depression, including persistent beyond 2 weeks of development of suicidal ideation. Okay, yes, because postpartum blue is self-limiting, it is premature to recommend psychiatric consultation or begin treatment with psychotherapy. Interpersonal psychotherapy, cognitive behavioral therapy, or antidepressant psychoeducation would be helpful at this stage. Psychoeducation would be helpful at this stage. Treatment can be considered if symptoms worsen and persist beyond 2 weeks. Patients with postpartum depression can be treated with psychotherapy and/or antidepressant. Sertraline is preferred antidepressant in women who are breastfeeding, as levels in breast milk are generally low or undetectable. I'm coming with. Extremely sorry. Yes. Okay. These patients' manic behavior, agitation, grandiosity, loud, pressured speech, and signs of sympathetic stimulation, diaphoresis, tachycardia, hypertension, mydriasis are consistent with cocaine intoxication. Patients under the influence of the cocaine or other stimulus may exhibit elevated or irritable mood, hyperactivity, agitation, and grandiosity that are indistinguishable from an acute manic episodes of bipolar disorder. Other manic symptoms such as grandiosity that are indistinguishable from an acute manic episode of bipolar disorder. Other manic symptoms such as decreased need for sleep, racing thought, grandiosity can also be seen in cocaine intoxication. Bipolar disorder is not diagnosed when there is an evidence of symptoms are caused by substance use or withdrawal. Okay, it's not brief psychotic disorder, which is characterized by acute onset of psychotic symptoms lasting 1 day to 1 month. Delusional disorder is characterized by more than one delusion lasting more than 1 month and that are not accompanied by other psychotic symptoms. This patient's psychiatric disorder would not explain this patient's physical findings. Okay. Okay. Sorry. Histrionic. I don't remember now. Okay. This patient's behavior is characteristics of narcissistic personality disorder, a pervasive pattern of grandiosity, need for admiration, a pervasive pattern of grandiosity, need for admiration, sense of entitlement, lack of empathy. Although these patients can often be charming and successful, and their motivation is to obtain constant attention or praise, often arrogant and boastful. They display an exaggerated sense of importance and frequently overestimate their abilities and accomplishments. These individuals have difficulty sustaining relationship because they are unwilling to recognize or identify with the feelings and need of others. They are often disappointed in relationship when their needs to be admired and to be the center of the attention are not met, as in this patient who is upset that her daughter chose help to a friend rather than to see her. In the medical setting, these patients may be demanding and feel entitled to special interest, being angry that the physician will not prescribe antibiotics over the phone, insisting on being seen immediately. Okay, it's not histrionic. Although histrionic and narcissistic personality disorder both characterized by seeking admiration and by need uh, to the center of attention and by the need to the center of the attention, patients with histrionic personality patients with histrionic personality disorder emotional coldness do not display emotional coldness, lack of empathy. These patients instead exhibit excessive emotionally overestimate the closeness of relationship, and they use seductive behavior to get their needs met. Okay. In histrionic, patient will show seductive behavior to get their needs met, and narcissistic like they are boasting of them, like they are proud of them. Is that how we can differentiate, or you have another idea? Histrionic, like they are showing seductive behavior to get their needs met, and narcissistic, they are actually proud of themselves. They are so proud of themselves, so they do not care about others, like this patient. Okay. Okay. BMI is normal, 19.2. So, okay, he is taking something cocaine. That's why his nasal perforation, erythema in the nasal mucosa. Okay, that's okay. I am looking for the erythema. I am just trying. Okay, okay. Cocaine is an stimulant, and that produces cocaine is a stimulant that produces increased energy, decrease appetite, and reduce need for sleep. Individuals who abuse cocaine often had mood changes, mm, irritability, and weight loss secondary to decreased appetite. This patient's diagnostic hallmark in this scenario is erythema of the nasal mucosa. Erythema in the nasal mucosa, which is common finding in individuals who snort cocaine. In severe cases, perforation of the nasal septum can occur. Occur. In addition to mood disturbance, other psychiatric complications of cocaine include anxiety, panic, grandiosity, psychosis, delusion or hallucination. Okay, it's not ABC. Like, okay, the physical findings of erythema of the nasal mucosa: normal weight, BMI 19.2 kg per meter square, and lack of characteristics features of eating disorder, discrepancy between the desired and perceived body image, make these diagnoses less likely. Anorexia nervosa is associated with intense fear of gaining weight and distorted body image despite a significantly low body weight, BMI less than 18.5 kg per meter square. Avoidant or restrictive food intake disorder involves lack of interest and avoidance of eating based on the scenario characteristics of food with typical onset of infancy or early childhood. Diagnosis of bulimia nervosa requires evidence of binge eating and compensatory behaviors. Got it? Okay. Next.
diagnosis.
Okay. Okay, it's adjustment disorder. These patients onset of anxiety and insomnia in response to these patients onset of anxiety and insomnia in response to major life change. Living alone for the first time is the most consistent with an adjustment disorder. Her insomnia and increased anxiety developed in relation to safely concern about being alone and fears of intruders at night. Her fatigue in turn negatively impacts her studies. An adjustment disorder involves emotional or behavioral symptoms, anxiety, depression, disturbance of conduct developing within the 3 months of an identifiable stressor and lasting no longer than 6 months once the stressor ceases. Symptoms of adjustment disorder are distressing and impairing, but do not meet the criteria for another psychiatric disorder. Symptoms are insufficient in number, severity, or duration for another specific diagnosis. Stressor can be single, multiple. In this case, they are multiple: moving away from home, living alone for first time, starting college, feeling academic stress. Okay, it's not OCD. The patient's worrisome thoughts are time-consuming and distressing. However, she does not describe them as intrusive, which should be typical of OCD. In addition, she does not display the repetitive, ritualistic, compulsive behavior characteristics of OCD. She checks the door only once rather than repeatedly in a compulsive manner. And option E, these patients new onset symptoms in response to new onset symptoms in response to a stressor cannot be explained by cannot be explained by personality disorder alone. Paranoid personality disorder involves a lifelong pattern of pervasive distrust and suspiciousness across a wide range of interpersonal contexts. Next. Psychotic, yes. Okay. Also, these patients worsening depressive symptoms, extreme functional decline, and meal refusal to sacrifice herself for the greater good, which, while insisting that she must die in accordance with divine plan, uh, is consistent with MDD with psychotic feature. Psychotic feature may be subtle or intermittent, but often include and or hallucination with depressive themes of desert, punishment, guilt, worthlessness, and catastrophe. First line management. First line management of antipsychotic depression consists of either first line management. mm, okay. First line treatment of psychotic depression consists of either antidepressant plus an antipsychotic or electroconvulsive therapy. However, uh, however, MDD is a psychotic feature. MDD with psychotic feature progress to suicide attempt in up to 25% of the patient. Therefore, when suicidality presents in this population, it should be treated aggressively. ECT can provide rapid reduction in symptoms. In the scenario, the patient's psychotic depression with a suicidal motivation to her meal restriction results in physical manifestations of dehydration, decreased skin turgor, dry mucous membrane with significant weight loss. She should be offered inpatient psychiatric treatment so ECT can be pursued. ECT is a safe and effective procedure that and has no absolute contraindication. It is typically administered 3 times a week for a course of 6 to 12 months. Okay. Apart from venlafaxine, none of them cause hypertension, dose-dependent hypertension, isn't it? Okay. Okay, venlafaxine, antidepressant in the serotonin norepinephrine reuptake inhibitor class, and has been associated with dose-dependent hypertension. At lower dose of venlafaxine primarily inhibits the reuptake of serotonin. Dose-dependent hypertension at lower dose venlafaxine primarily inhibits the reuptake of serotonin as dose increases. However, the drug also inhibits norepinephrine reuptake, potentially causing increased systolic and diastolic pressure. The hypertensive effect is especially significantly at doses. The hypertension effect is especially significant at doses more than 300 milligram daily, in which the incidence may be 10%. Although blood pressure increase is generally modest for most patients taking venlafaxine, blood pressure should be monitored regularly. It, if sustained increases are noted, dose reduction or discontinuation should be considered. In patients with pre-existing hypertension, blood pressure should be well controlled prior to starting venlafaxine. And an alternative antidepressant with a more favorable side effect with a more favorable side effect profile should be considered. Okay, okay, other options are not that important. Oof. Okay, you are in between borderline and oh no, you are in between disruptive and okay. I thought that it may be borderline. Okay, this patient's pattern of impulsive this patient's pattern of impulsive aggressive behavior is suggestive of intermittent explosive behavior and impulse control disorder. Intermittent explosive behavior. Patients with IAD are unable to restrain their aggression impulses, resulting in verbal or physical aggression that is out of proportion to the provocation. The violent impulsive outburst is typically preceded by rising tension that escalates rapidly to a state of a rage without thought to the consequence of the behavior. Episodes last less than 30 minutes and may provide an immediate sense of relief, usually followed by remorse, dysphoria, embarrassment, significant impairment due to interpersonal difficulties, job loss, school suspension, legal problems. IED tends to be chronic and is associated with high rates of psychiatric comorbidity. It should not be diagnosed if impulsive, aggressive behavior occurs exclusively in the context of another active psychiatric disorder, acute manic, or episodes in bipolar disorder. Treatment is CBT and SSRI. Yes. Okay. see, patients with borderline personality disorder may exhibit inappropriate anger and rages, but these outbursts typically occur in the context of an unstable relationship and are related to underlying fears of abandonment. This patient's lack of characteristics This patient's lacks other characteristics borderline features elevated mood, increased energy, decreased need for sleep, and pressure speech. Elevated mood, increased energy, decreased need for sleep, and pressure speech. Okay. Okay. DSD, like these disrupt sorry, not DSD, like disruptive mood dysregulation disorder. Okay. Disruptive mood dysregulation disorder may present with disproportionate verbal or physical outbursts. Diagnosis require onset less than before 10, with persistent irritability or anger between episodes. Okay, the diagnosis is not made after 18. So diagnosis is not made after 18. Okay, it should be within the 10 before. Yes. Yes. Intermittent explosive disorder, onset age onset after age 6. Yes. Okay, look at this first aid. So can you see my screen? This is disruptive mood dysregulation disorder, onset before age 10, and the IED, intermittent explosive disorder, onset after age 6, and outburst last less than 30 minutes. So there are these two things is important, like onset age before 6 and outbursts last less than 30 minutes and outer proportion to provocation and may lead to legal, financial, and this and that, and psychotherapy and SSRI. Okay, and it is like oppositional defiant disorder, ODD. Oppositional defiant disorder, there is also six, but it lasts more than 6 months. There is pattern of anger and irritability with argumentative and vindictive and defiant behavior toward authority. So we know that oppositional defiant is regarding to the authority figure, isn't it? Okay. So oppositional defiant is authority figure. It lasts more than 6 months. Okay. Now, yes. So, okay, active substance use, including alcohol and precipitation, and active alcohol use including alcohol and precipitation. Sorry, alcohol and uh, prescription and or illicit drugs is associated with increased risk of suicide risk, both adolescent or adult. Although these patients' age, sex, family history, psychiatric illness are static factors that contribute to her risk of suicide attempts, her benzodiazepine use, taking her mother's clonazepam to help her sleep has disinhibiting effects that more increase the acute suicide risk. Substance intoxication substance intoxication in adolescent especially heightens the impulsivity and poor judgment, and generally seen in this age group in combination with psychiatric disorder MDD, MDD and a major and a stressful life event caught cheating at a test as seen in this patient. Disinhibition from substance use can play a major role in suicidal behavior. In some studies, antidepressant medications have been associated with a slightly increased risk of suicidal thoughts behaviors in adolescents compared with placebo, resulting in FDA black box warning. However, the evidence is inconclusive. However, the evidence is inconclusive with the expert consensus favoring antidepressant use. This patient's depression had improved on escitalopram prior to the stressor of being caught cheating making antidepressant making antidepressant initiation is a less likely contributor to her suicide risk. Okay, okay, okay. This this patient most likely has pseudopsoriasis, a persistent non a persistent non-delusional belief of being pregnant in a non-pregnant patient. Patients commonly experience symptoms of early pregnancy such as amenorrhea, morning sickness, and abdominal distension, but evaluation excludes negative results on office urine pregnancy test, thin endometrial stripe on ultrasound. Pseudocyesis can occur when psychological pressure, difficulty conceiving as in this patient, social pressure, and the somatization of stress affect the hypothalamic pituitary ovarian axis, or when boldly changes, weight gain, amenorrhea are misinterpreted by the patient. The end result is deeply held non-dysfunctional. End result is deeply held non-delusional belief of being pregnant that may be strong enough to cause a patient to misread a uh, negative home negative home test result as positive. Because pseudocyesis is a form of somatization, management required psychiatric evaluation and treatment. Okay, visual disturbance. Some sort of psychosis. Okay, management of psychosis in patient with Parkinson disease. In patients with Parkinson psychosis, yes. Infection, delirium, dementia present, yes. Workup and treatment. Workup and treat infection. Manage delirium or dementia. Workup and treat infection. Manage delirium and dementia. Infection, delirium, dementia present, no. Minimal symptoms, no. Minimal symptoms, yes, then monitor. Minimal symptoms, no. Improve with reduction or discontinuation of non-PD medication, sedative, anxiolytic, no. uh, Improve with reduction, discontinuation of PD medication starting with least dose potent, no. Initiate antipsychotic with low T2 antagonism like pimavanserin, quetiapine, and clozapine. Okay, we will try to reduce the medication first. So reduction of discontinuation. First non-PD medication, then the discontinuation of the PD medication. Then if they, then the after that, if the psychosis does not improve, then we will add the low dose antipsychotic. So so do they so sertraline sertraline is not sedative and anxiolytic. They are talking about the sedative and anxiolytic, not the antidepressant. Maybe because sertraline reduction may be helpful, but I don't think so. It it is not sedative or anxiolytic. Anxiolytic like benzos, sedative and anxiolytics. Okay, okay, I'm now reading the explanation. So this patient with established Parkinson disease PD has new onset visual hallucination consistent with psychosis, that is hallucination, delusion or illusion. Psychosis is a common complication of Parkinson disease affecting up to 40% of the patient. It can result from dementia, delirium, infection, psychoactive medication, anti-Parkinson drug, and underlying disease progression, increased risk of duration. In the absence of dementia, delirium, clear sensorium, retained insight, and infection, normal vital sign, no other symptoms. The most likely precipitant is medications. The first medication priority is to reduce or discontinue non-essential medication with psychoactive properties that may be contributing to psychosis. Anticholinergic, anxiolytic, TCA. However, unlike tricyclic antidepressant, SSRIs have low. However, TCA and SSRIs have low anticholinergic activity and are less likely to induce psychosis. So they are less likely to induce psychosis, and increasing or reducing this patient's sertraline is unlikely to improve psychotic symptoms. But anti-Parkinson drug works via D2 receptor activation, and therefore they are important triggers of psychosis in PD. Stopping all anti-Parkinson agent is not usually feasible, but reducing this dose is often possible with close monitoring, in a patient with well controlled, especially in a patient with well controlled symptoms. Anti-Parkinson drugs should be gradually reduced to the minimum needed dose in a sequence that balances motor symptom effectiveness with psychosis, triggering potential taper anticholinergic first, followed by dopamine agonist. Therefore, for this patient whose Parkinsonism is controlled, mild tremor, minimal rigidity, the carbidopa levodopa dose should be reduced as tolerated. Yes. She's on psychosis, isn't it? So fast generation is preferable? You give your answer. I don't know actually. I am just talking to myself. Yeah. Yes. And lorazepam are usually for seizures like diazepam, benzodiazepine. Okay, we are away from the explanation. Okay, these patients exhibit symptoms of acute psychosis, grossly disorganized speech, behavior, probable hallucination that most likely due to schizophrenia. Differential diagnosis of schizophrenia requires ruling out of other psychotic disorder, mood disorder with psychotic features, substance-induced psychosis, and psychosis secondary to general medical conditions. Because the patient is cooperative, initial treatment with oral antipsychotic medication is appropriate. Medication selection depends on a patient's history of response as well as medication side effect profile. Second generation antipsychotics such as aripiprazole are often chosen due to their lower risk of extrapyramidal side effect tardive dyskinesia compared with first generation antipsychotic. So second generation antipsychotics such as aripiprazole is often present due to their lower risk of extrapyramidal side effect tardive dyskinesia compared with first generation antipsychotic. With the exception of clozapine, there is no evidence that one antipsychotic is more effective than others. If further evaluation indicates a pattern of repetitive medication non-adherence, switching to a long-acting injectable antipsychotic. Switching to a long-acting injectable antipsychotic could be considered. However, this should be done only after the patient's ability to tolerate the oral formulation and therapeutic doses is established, making long-acting injectable antipsychotic inappropriate choices of initial agents. Uh, if this patient tolerates and responds well to oral aripiprazole, then subsequently switching to long-acting formulation of aripiprazole should be considered. Okay. Okay. So young children are naturally curious about their bodies, and its development is normal for toddlers and preschoolers to touch their own and or other young children's genitals. Occasional genital self stimulation is common and is asking about reproduction, playing doctors with other children, dressing in a typical um, clothing of other gender, and attempting to undress themselves or others. These behavior are usually brief and distractible, should be should not be stigmatized but rather redirected if inappropriate, like self stimulation in public. These behavior typically decrease as children approach adolescence, when they become more aware of social norms and expectations and have increased need for privacy. However, sexual behaviors that are concerned in young children, such as precocious sexual knowledge, preoccupation with masturbation, excessive or aggressive talk about sexuality, simulating genital or orogenital or anal genital contact. The reports the reports by the first mother about stimulation of oral sex with dolls should be explored further. Knowledge about specific details of sexual acts would be concerned in a 4-year-old child. Anogenital trauma, coercive sexual play, repetitive UTI with no medical cause should raise concern about possible sexual abuse. Okay. Is she panicking because she left in between the voice. Yes, there are lots of features also panic, like tightness, choking, in, mental status. Mental status. So she has social phobia. Like, okay, why they haven't used SSRI? Okay, it's performance type only. Okay, when she is she has phobia when she is on speech. Oh, okay. Okay, this patient's performance anxiety, which is classified in DSM-5 as social anxiety disorder, performance only. Individuals with performance only social anxiety do not fear non-performance social situations and are not socially avoidant in general. The pharmacological treatment of performance only the pharmacological treatment of performance only social anxiety disorder include as need beta blocker benzodiazepine rather than maintenance medication. Beta blocker propranolol as needed, basic propranolol on as needed basis help control the associated autonomic response, tremor, tachycardia, diaphoresis due to their addictive potential. Benzodiazepine, diazepam, lorazepam are generally avoided in patients with personal or family history of substance use disorder. In addition, they are preferred when performance could be impaired by sedation or cognitive side effect. Given a presentation as in this case, cognitive behavior therapy is effective non-pharmacologic approach. Okay, social anxiety disorder. If we look at the box, there is marked anxiety about one social situations for more than 6 months. So, difference between GAD and social anxiety just social situation, isn't it? Like in generalized anxiety disorder, there may be excessive, like more than one or more uh, anxiety, excessive worrying or anxiety for more than 6 months. Okay, there is fear of scrutiny by others, humiliation, embarrassment, social situation avoided and endured with intense distress, marked impairment, subtype specifier performance only, treatment SSRI, SNRI, CBD, beta blocker or benzodiazepine for performance only subtypes. Next. Okay, taper and discontinue risperidone. So this patient facial grimacing combined with foot tapping and inversion movements are most likely signs of tardive dyskinesia caused by exposure to risperidone, a second generation antipsychotic in the treatment of bipolar and psychotic disorder. Although most commonly associated with first generation antipsychotic and antiemetic metoclopramide, tardive dyskinesia may also occur with some uh, uh, with some okay, the risk of tardive dyskinesia varies significantly within the SGA class. Risperidone is the is among the highest risk of SGA. Risperidone is the highest risk of SGA, whereas clozapine and quetiapine is the lowest risk of SGA. Okay, patients receiving maintenance antipsychotic medication should be assessed for tardive dyskinesia at regular interval and causative medication tapered and discontinued if feasible. The patient has been stable, no recurrent mood episodes for 3 years and may not require maintenance risperidone because lithium may adequately control her symptoms. Therefore, a gradual taper and discontinuation of risperidone, of the risperidone is most appropriate initial management when antipsychotic reduction or discontinuation is not feasible. Treatment options include switching a lower risk agent clozapine and treatment with VMAT 2 inhibitor valbenazine deutetrabenazine. Okay, box. Tardive dyskinesia is abnormal involuntary movements due to prolonged use of antipsychotic or metoclopramide, oropharyngeal dyskinesia, limb dyskinesia, trunk dyskinesia. Oropharyngeal dyskinesia is trunk protrusion, lip smacking, grimacing. Limb dyskinesia is dystonic posture, foot tapping, chorea. Trunk dyskinesia is rocking, thirsting, shoulder shrugging, rocking, thirsting, shoulder shaking. Greater risk with first generation antipsychotic. Management is discontinue causative medication if feasible, switch to second generation antipsychotic, quetiapine, clozapine if antipsychotic is required, and treat with valbenazine and deutetrabenazine. Yes. Is it panic? Okay. Okay, it's DPD, dependent personality disorder. So this patient excessive reliance on his girlfriend's submissive behavior, agreeing to get a cat despite allergies, inability to make decisions on his own are characteristics of dependent personality disorder. Individuals with DPD have a need to have a need to taken care of and have others manage their life. They fear separation, they lack confidence in their ability to manage their affairs, and they struggle to make decisions without input and approval from others. Patients with DPD often have symptoms of anxiety, such as these patients' panic attack or depression in the context of breakup or loss of relationship, which triggers their sense of inadequacy and fear of being left to uh, tend themselves, seeking another source of care and support when a close relationship ends. This patient's moving in with his parents is characteristics. Okay, this patient remains symptomatic despite the best efforts of the physician to treat with multiple medication trials, and she rejects all recommended non-pharmacologic approach. Such patients believe that no treatment will help and appear not want to improve. They are often frustrating to manage and can leave the physician feeling angry and manipulated. The understandable tendency want to refer this patient to another provider or specialist should be avoided. So this patient often have underlying depression but will refuse to referral to a psychiatrist. Okay, they are needy for attention and unconsciously wish to remain symptomatic so that they can contribute to see a physician. The best approach is empathize with them and attempt to engage them in a collaborative plan in which there is mutual agreement among realistic treatment approach and limited expectation. Empathizing with the patient's frustration over disappointing outcomes and focusing on alleviating of symptoms rather than cure is often helpful. Okay, okay.